I'll be presenting our experience on diabetic retinopathy screening and diabetic retinopathy to pick up the undetected. So to start with, just some few information about our state, Kerala, southernmost state of India. It has got very good literacy rate, more than 95%, with a very good human developmental index comparable to many developed countries in the world. This is a depiction of prevalence of diabetes by Mohan et al. Beautifully depicted. Kashmir Valley recording the least, 6.1%, and Kerala recording the highest, 16.3 to 19.5%. So there is a health issue here, and for as far as diabetic retinopathy is concerned, it was found to be 26.8% among self-reported diabetic patients in Kerala. So there is a problem now, and to address any problem, we have to understand the magnitude. As I just show you the map, it is different in different states. So we can't rely on any old data, 10 years old data. So we have to understand the magnitude first. For that, what we did was we launched a survey in a reference population in our state, in Ernakulam. It's called Chengamanadu Village. We covered around 6,211 respondents over the age of 40 years with the help of MSW graduates, and a questionnaire which had demographical as well as knowledge, attitude and practice questionnaire about diabetes and diabetic retinopathy. And this was the Chengamanadu Village which I just mentioned. And we found that the literacy rate was very good. More than 95% of the population was above 40 years were literate. And a very interesting finding, we found that more than 35% of this group were having some kind of health insurance. Government sponsored, state ESI sponsored, or a private or company sponsored. Some kind of insurance were there for more than for about 35% of this group. And diabetes, we found that self-reported diabetes was seen in 25% of the population. That is, 1 in 4 more than 40 years were found to be diabetic, very high prevalence. So there is an issue. Now coming to the knowledge, they had very poor knowledge about the diabetes. More than 53 had poor knowledge. Diabetic patients also, 57 had poor knowledge. These were the questions which are asked to assess the knowledge. And a very major, serious concern we came across was more than 60% of the patients were not told about the complications of diabetes or to have an eye checkup by the treating physicians. So they have to be the primary source of information about the complications of diabetes, but they were never told about a yearly screening for diabetic retinopathy. And attitude was negative among the participants, general participants and the diabetic patients, and the practice among diabetic patients was also found to be poor. So there is a lack of awareness. In spite of why I mentioned literacy again and again, in spite of a good literacy, they had poor awareness, poor knowledge, a negative attitude and a poor practice. So to address this problem now, we have to intervene. So what we did is, we launched a community interventional program to create awareness among health workers first, healthcare professionals. So they are the one who have to make, you can't create awareness about among population straight away. So you have to create awareness among health professionals first and then go for the public. So we created, we designed a program where we can cover the healthcare professionals. We covered the entire state in 3 phases. Started in March 2011. This is an example phase 1 program covering 4 districts. We targeted ophthalmologists, of course, general practitioners who are treating physicians or general practitioners or physicians, optometrists, ophthalmic technicians, medical social workers, health inspectors and volunteers of NGOs who were interested in this. And we conducted seminars, symposium, CME, skill transfer courses, workshops, etc. We created some educative pamphlets for this purpose, and we trained some ophthalmologists for medical retina. From each district we selected some of the candidates and we trained. And general practitioners and physicians to IMA and the other physicians forum, we try to educate them about the condition. Optometrists and technicians across the state, in their conferences, we went and presented this particular topic and the importance. And volunteers of non-governmental organizations, health inspectors actually these people are very important, health inspectors. They have to give permission for conducting camps, they will come and inspect. So they have to be aware of the condition, the status. And most important group was the social workers. And the ASHA workers and the Kudumbashree exclusively for the Kerala state. We trained them, we made them aware about the condition. And these were the... now, after this project, we had some models with which we can actually go and intervene into the community for this particular issue. So, very unfortunate to say that doctors gave a poor response. Among all the groups, doctors were giving poor response, and social workers did very well. They were interested, they came forward, we planned some strategies for. So I will be giving 2-3 models which we found to be very effective. Model 1 was to train a medical officer in a PHC, and he will train his social workers, and the social workers act with door-to-door access, and they will go to, they can identify the diabetes patients in that particular ward or panchayat. Each and every household they know. So identify diabetic patients, door-to-door counseling, then educate with pamphlets, and then conduct a screening camp for a group. So this was found to be very effective, and one of the examples, 92 social workers trained in the panchayat. We covered almost 752 patients screened, and we found 168 new cases. So till now we have a passive detection of diabetes and diabetic retinopathy. That is, they will come with a problem to us and we diagnose. This is a model where it is an active case detection strategy. We go to the community and find out. So this is actually, this one was found to be very effective, and especially in geographical isolated areas like island where there is no access. We have an island called Mulavagad. We went there and screened some 266 patients, 35 new cases of diabetic retinopathy detected. So another model is by the physicians. I told the group which had poor response. Some of the doctors were very interested, and they formed a diabetic club. And this is the largest diabetic club in our Kerala, the Paravur Diabetic Club of 1,211 members, diabetic patients. And past 3 years we are conducting screening programs for them in batches, and educational programs and update on the disease we were giving. And 155 diabetic retinopathy cases being followed up through this diabetic camp. So this is we found very effective. Diabetic clubs by a group of doctors. Through IMA or some other organizations, you can form diabetic clubs in one particular area. You will not miss a single diabetes patient then. Now another model is through the local self-government administration. This is the same panchayat where we conducted the survey, and this is again a health workers based model. The panchayat president was the headed the program. Diabetic patients they had a register of diabetic patients, and we know from the survey we know each and every name of the diabetic patients with their house numbers. So we were able to collect them in a place. We conducted one camp for 3 wards, and this was also found to be this model was found to be very effective. And one step ahead, some of the patients in Chengamanadu Village was not able to come for the screening program. What we decided is we had a mobile unit with a mobile cam. We know nowadays non-pediatric cams are there. We can send the pictures immediately to the base and get. So one optometrist was given in charge. They went to the house where the patient was not able to come, and screen that patient and send the images to the base and identify the problem. When there was a problem, they will refer to the base. So as I showed you, now there is a passive case detection system. I have shown some models where you can do an active case detection system which will be more effective. You can't one hospital or one institution can't cover the entire state. You have to customize one program for yourself. You have to customize the active case detection for your state, your place. So our country, especially in our state, we are facing a demographic transition. We are heading towards negative population growth. That is, after 20 years, there will be more elderly people. So what will happen? There will be more elderly related diseases, especially diabetes. So this is going to be a major health issue after some time. So this strategy, I think, will help us to pick up the undetected. We have to first understand the magnitude of the problem, then launch a community-based program to make them create awareness and to create awareness amongst healthcare professionals, diabetic patients, as well as general public. And then you create your own active case detection model, which I have showed some few examples, and then accomplish the mission of preventing avoidable blindness due to diabetic retinopathy. Thank you.